Bom dia. Thank you very much for inviting me to the Congress of Brazilian Spinal Surgery. This is a perfect setup for the case, and my charge is to talk about optimal timing for surgery for traumatic cervical spinal cord injury. And hopefully I will convince you that early surgery, like it was done in this case, is the right thing to do. These are my disclosures. Most of this is grant support for what will be my third talk today, which is our research program in imaging, so it's not relevant to this particular presentation. This is my team. I want to specifically acknowledge Dr. Marjorie Wong, who's also here at this Congress, who's a valued colleague, and all of our students and clinical fellows and residents, which basically make our team work. This has nothing to do with the case that has been discussed. This is a picture of my home on Sunday on the left, which is with my car is stuck in the snow. And on the right side is yesterday. So I'm very grateful to Dr. Ricardo Botello and Astrobal for inviting me here. It's much warmer and nicer here. So thank you. So the case was presented. This is a retropulsion of C6. What was shown was a bilateral lock facet, but it's essentially a similar problem. You're on call. It is now 8 p.m., worse than what was shown in the case, which was 10 a.m. And when should you operate? That's the question. So the debate is, should we operate on spinal cord injury patients early, both complete, especially the complete patients, as well as incomplete? When should we operate? Why should we operate early? And what is the evidence? So what I'm trying to do is to convince you for the case for early surgery, by which I mean under 24 hours. So I want to present to you evidence from history, from the pathophysiology of spinal cord injury, from imaging, from preclinical animal data and studies, evidence from clinical experience, and finally some legal implications as to why it would be good to operate early. What is the rationale? So for example, I understand this is an audience of predominantly neurosurgeons. When you think about stroke, time lost is the same as tissue lost. The way we treat stroke is we try to get the patient to the needle as quickly as possible for thrombolysis. If you think about intracranial or extracranial compressive lesions like epidural hematomas or subdural hematomas, time lost is again representing tissue lost. But why do we debate for spinal lesions, extraaxial and intraaxial? So that's one of the reasons why it is not a consistent treatment patterns, which is why I want to present this evidence. Historically, 2,000 years ago, Galen of Pergamon recommended early traction after a patient was injured in the spinal cord. So this concept of realigning the spine in order to try and help the spinal cord injury situation is not new. It has existed for almost 2,000 years. If you look at pathophysiology, Dr. Charles Tatter at the University of Toronto first published the concept of secondary injury. So here's the primary injury, and here's the cascade of events that result in a much larger area of tissue being lost because of secondary injury. This is caused by a number of molecular phenomena. For example, alterations in local ionic concentrations, changes in blood flow, breakdown of the blood-brain barrier or blood-spinal cord tissue barrier, and penetration of serum proteins causing apoptosis of cells at the molecular level in the spinal cord. In fact, a number of clinical trials, and this will be the topic of my next talk, are based actually on reducing the functional loss from the secondary injury. So these include the hypothermia trial that is being run by the University of Miami, the Accorda and Asubio trials that were run nationally in the United States, the Riluzole trial that is now an international phase 3 trial, the INSPIRE neurospinal scaffold trial by In Vivo Therapeutics, and the Cethrin trial. They're all based on the pathophysiology of acute injury worsening after spinal cord injury and an attempt to reduce that. From an imaging perspective, Bizan Arabi from the University of Maryland has shown that in cervical spinal cord injury, in the early stage after injury, there is significant cord swelling and intramedullary hemorrhage that affects the motor score, and that maximum spinal cord compression, hemorrhage, and cord swelling are associated with poor neurological prognosis. In fact, there was a significant higher rate of lesion expansion that was described in Asia A and B patients, which are more severely injured, compared to the Asia C or D patients. We have done diffusion MR studies, which again we will talk about both for spinal cord injury and cervical myelopathy a little bit later in the morning. But we've shown essentially that diffusion metrics in the spinal cord after injury correlate with the Asia score with non-hemorrhagic stroke. So what I talked about earlier was the hemorrhagic type of spinal cord injury, but even in non-hemorrhagic spinal cord injury, as would be expected in the case presented with the jumped facets, there is a significant worsening of DTI metrics, and it improves with early decompression. There are a number of animal and preclinical studies that also support this concept. When the CLIP application model was developed at the University of Toronto, it was shown that early decompression improves neurological outcomes, and that longer durations of compression worsen functional outcomes in these animals, and that decompression within 60 minutes was much better than decompression which was undertaken greater than 4 hours after injury in the animal model. Again, there was a randomized study of 65 rats that came out in spinal cord in 2013, again showed improved function in the decompressed animals in the 8 and 24-hour group versus the 2-day group. So again, this is showing earlier decompression is better for functional outcome. There's a number of meta-analyses. So here's one looking at Julio Furlan looked at 19 papers out of 198 abstracts that provided some information about early decompression, and 13 out of the 14 papers decompression improved outcomes, and there was a clear biological rationale to support a potential beneficial role for decompression after acute injury. Another database analysis, looking at PubMed, the ISI Web of Science, and the Embase databases, this was conducted by Paul Batchelor, showed that early decompression improves neurological outcomes by an average of 35%. And neurological improvement is directly proportional to the degree and to the duration of compression. And finally, with the animal studies, 8 articles that were looked at from 1990 to 2013 also again showed that acute decompression significantly improved neurological outcome. This has been supported by a number of clinical studies as well. So there was recently a 20-question survey disseminated to 971 spine surgeons worldwide through an AO spine database, and this was simply to ascertain what the feeling was among surgeons worldwide as to when they would perform the decompression. So it's not surprising with the debate that exists that only less than half, or 46% of surgeons, said that they would perform early decompression for complete cervical spinal cord injury. The need to intervene early has been looked at, again, starting at the University of Toronto for a number of years, led by Dr. Tatter. And initially, the intent of these studies was not to see if early decompression was beneficial, but to actually see if a hospital system could actually even do the early decompression. Did you have the surgical support? Did you have the operating room support? Did you have the right team, etc.? So the first paper in the clinical evidence piece shows that the surgery was feasible, but more importantly, reduced the mortality in spinal cord injury patients compared with a non-surgical approach. In that paper, there was no significant change in hospital length of stay or to neurological recovery. The next paper, again from the Tatter and Failings group, came out in 1999. They looked at 585 patients within a 24-hour post-injury period in 36 different centers, mostly in Canada. And again, there was a significant variability, as you see, in terms of when the surgery was performed. And the real outcome of this paper was that they indicated the need to perform a randomized clinical trial. But again, this was about 20 years ago, and the problem was at that time, most people or most centers did not have the facility to perform early surgery, at least within 24 hours. So a number of meta-analysis have been done too. So 22 papers were reviewed out of 153 abstracts, again by Julio Furlan, who also published the animal data that I talked about earlier, and showed that in this analysis, early surgery was associated with reduced length of stay and reduced ICU stay, also reduced pulmonary complications and reduced blood loss. And that early surgery was safe, associated with reduced length of stay and reduced pulmonary complications. Although Vaccaro in Philadelphia started to do the early prospective study with a randomized clinical trial, The real landmark paper is the Staskis paper, which a lot of you are probably familiar with, that evaluated early versus late decompression for traumatic cervical spinal cord injury. And this was a multi-center study done prospectively, actually a very well done study. And 470 patients were screened, 313 were enrolled. There was equivalent match between the early surgery cohort and the late surgery cohort. There were equivalent number of mortalities and equivalent number of patients lost to follow-up. So there's a significant number of follow-up, with 131 patients having 6-month follow-up in the early surgery group and 91 patients in the late surgery group. The most important takeaway message from this study was that there was at least a 2-level AIS grade improvement and 6-month follow-up in the early surgery group. In addition, there was also a reduced urinary tract infection, reduced pneumonia, reduced cost of hospitalization, which is a big situation in the United States, with $6 billion being spent for the care of chronic spinal cord injury patients, reduced length of stay, and reduction of overall complications. So with this in mind, the AO Spine Knowledge Forum for Spinal Cord Injury, which I am a part of, undertook a systematic review collaborating with the Institute of Medicine. And we started this review process for a number of things: early intervention after spinal cord injury, the anticoagulant use, the use of methylprednisolone, the evidence for imaging. A number of key questions were asked, and the results were published in a series of papers last year in the Global Spine Journal in October. This paper deals with the early surgical intervention, and the key questions asked were: what is the efficacy and effectiveness of early decompression? Does timing of decompression influence function? What is the safety profile, and what is the evidence that early decompression has differential efficacy in subpopulations? The search period extended through November of 2014. 449 articles were reviewed, 352 were excluded, and 52 underwent critical review, of which 6 articles met all the inclusion criteria. Sample sizes were comparable in both groups. Both groups were found to have a male predominance with a relatively young average age. And clinically significant improvement was defined as AIS or Frankel improvement greater than or equal to 2 grades, or a 5-point or more improvement in Asia Motor Score. This is the list of the clinical studies that were actually met the inclusion criteria. And the conclusions were essentially that early surgery confers neurological benefit in acute spinal cord injury. The evidence from pathophysiology, preclinical, and clinical studies was supported by imaging data, and secondary outcomes were also significantly improved. Finally, some words about the legal implications. This is a paper that came out in 2015. 73 cases of spinal cord injury with deficit were reviewed between 2000 and 2010. Again, the average lawsuit, and this is in the United States, was 1.5 million. The thoracic lawsuits were the highest. Surgeons were most vulnerable, and obviously delays in treatment affected the legal defensibility in these cases. So again, so you're on call, it's 8 p.m., what do you do? What we have at our institution is availability of a spine trauma team, access to the operating room, anesthesia commitment for surgery within 24 hours, and quality review at monthly trauma PI meetings. Obrigado.
Thank you.